Welcome everyone. Welcome to ICODAAS 2025. First, I would like to invite David Tejeli, the President of the Anti-Drug Commission of TRMC, and she is the host and the President of the Anti-Drug Commission. And as she will be giving her speech in Turkish, I'm going to translate it.
Saygıdeğer bilim insanları, değerli konuklar.
Yeah, distinguished scientists and esteemed guests.
Hepiniz ICODAAS 2025 International Conference on Drug Abuse Addiction Studies'e hoş geldiniz.
Welcome to International Conference on Drug Abuse and Addiction Studies, ICODAAS 2025.
Kuzey Kıbrıs Türk Cumhuriyeti Başbakanlık Uyuşturucu ile Mücadele Komisyonu olarak bağımlılıkla mücadelenin yalnızca tedaviyle sınırlı olmadığını, araştırma, veri üretimi, politika geliştirme ve insan onuruna dayalı sosyal dönüşüm ve anlam kazandığını biliyoruz.
As the Anti-Drug Commission of the Prime Ministry of TRMC, we believe that the fight against addiction goes far beyond treatment. It finds meaning through research, data production, policy development, and social transformation based on human dignity.
Komisyonumuz bu vizyonla Dr. Zafer Bekiroğlu'ları işbirliğinde yürütülen pek çok uluslararası çalışmaya öncülük etmektedir. ICODAAS bu işbirliğinin somut bir sonucudur.
With this vision, our commission has led many international initiatives in collaboration with Zafer. And ICODAAS is one of the outcome of this partnership.
Ayrıca ESPAT 2024 verileri tamamen komisyonumuz tarafından hazırlanmış, Profesör Dr. Merlit editörlüğünde uluslararası yayına hazırlanan kitabın temelini oluşturmuştur. Bu eser Kuzey Kıbrıs'ın bilimsel üretimde geldiği noktayı simgelemektedir. Türkçe baskısını ülkemizde paylaşmayı büyük bir heyecanla bekliyoruz.
In addition, the ESPAT 2024 data fully prepared by our commission formed the foundation of a book edited by Professor Dr. Merlin and prepared for international publication. This symbolizes the scientific process achieved by Northern Cyprus. We look forward with great excitement to sharing its Turkish version in Cyprus on February as well.
Başkanlığımdaki komisyonumuz yalnızca kurum değil, bir inanç topluluğudur. İnsanın değişme ve iyileşme gücüne inanan bir yapıdır.
Our commission, under my leadership, is not merely an institution, it is a community of belief built on faith in humanity's capacity for change and recovery.
Bilimsel işbirliklerimiz, rehabilitasyon programlarımız, sosyal yön projelerimiz ve önleyici çalışmalarımız ülkemizin gençleri ve aileleri için gerçek bir koruma kalkanı oluşturmaktadır.
Our scientific collaborations, rehabilitation programs, social reintegration projects, and preventive efforts create a true shield of protection for the youth and families of our nation.
Son olarak sizleri komisyonumuzun sosyal uyum ve tedavi süreçlerine katılan, şu anda temiz ve iyileşmekte olan bireylerin büyük emekle hazırladığı özel hediyelerle buluşturmak istiyorum.
Finally, I would like to present you with special gifts prepared with great dedication by individuals who are now clean and in recovery, actively participating in our Commission's social reintegration and treatment programs.
Sahneye davet edeceğim Feyza, iyileşme danışmanı ve benim ilk danışanım kendisi. Sizlere kendi danışanlarının kendi elleriyle yaptıkları el yapımı takıları takdim edecek.
I will invite Faisal to the stage. My first honor, by the way, to give you a brief information about Faisal, because I asked her permission that she allows me to share it. She used to be synthetic cannabinoid addicted for many years. She's clean for 8 years now, and she's the first client of Tayfida. Now she's working at the Anti-Drug Commission as a consultant, patient consultant, and she brought the presence of her own clients.
Wow.
So,
Bu hediyeler yalnızca bir obje değil, insanın yeniden doğuşunun, umudun ve özgürlüğün sembolüdür.
These gifts are not merely objects, they are symbols of rebirth, hope, and freedom.
Şimdi bu büyük emeği paylaşan çok değerli bilim insanlarını sahneye davet etmek istiyorum. Profesör Doktor Merlin.
So, someone?
Burada olması lazım. Gel.
Yeah, so.
Beautiful card. Oh, with things in it. This necklace carries the story of a soul that fell apart, learned to breathe again, and found beauty in the pieces. Wow, thank you. Beautiful necklace. I will wear this proudly. Oh.
Yes.
All jewelry does this for sure. That's great. I'll straighten it. Beautiful. Thank you very much. So I am Professor Dr. Marilyn Eustace, and I am very proud to be here. I had the pleasure of meeting Tafeda and Zephyr and Manlis, wherever Manlis is, over there, last year, and I was so impressed with your vision. Do you want to translate?
Geçen yıl tanışma şansı oldu ve sen çok etkilendi.
With her vision for what she wanted to do with the Anti-Drug Commission.
Yeah.
And she has ideas for prevention, for treatment. I had the joy of seeing the brand new treatment building in Nicosia and meeting people like Tafeda and also the clients and what they're working with, but also wants to do so much more.
Şeyle ilgili yeni binayla ilgili olarak onun şeyini paylaşır, artık yapmak istediklerin sadece prevention yani önleme değil, işte tedaviyle ilgili de.
With creating the SPAD survey in North Cyprus.
Yani ESPA'da Kuzey Kıbrıs'ta yapıyorum.
And data is knowledge. So being able to know what the problems are, where the problems are, then you can work on creating treatment and
Böylelikle elinde data senin ülkene ait, KKTC'ye ait ve sen bununla ilgili olarak da neyle uğraştığını, neyi engellemeye ya da tedavi etmeye çalıştığını çok daha rahat görün ve bunu yapıyor olmandan da sevinir. Yani etkilenir.
And they're opening a brand new inpatient treatment unit. They're working on it right now. So she's really turned over what was being done in North Cyprus and recognizing the problem and making a much better future for your people.
Bu yeni olacak olan merkezler çok değerlidir. İnsanlara sadece önlem tedaviyle ilgili olarak da çok ciddi yardımda bulunuyor olmasıdır senin liderliğindeki o süreci.
It takes longer to say in Turkish.
It takes me time.
So I am proud to be here, and I want to thank all the speakers who are here and all of the attendees that are here and all of you that are online, because this is a new beginning, another beautiful approach to the problem. So thank you so much for being here. And I am going to tell you, as they asked, a little bit about myself. So I am Professor Dr. Marilyn Hustis, and I was a military child and a military wife. So I've lived in 26 US states. Took me a long time to get my education completed. So I started my PhD at 40, first paper at 42, and I had 592 papers. So I was very lucky to be at the National Institute on Drug Abuse, at the National Institutes of Health for more than 23 years, and got to do controlled human drug administration studies, which was such an honor, such a challenge, such an opportunity. And the best part of my job was having wonderful people come through and do their PhD with me through the University of Maryland and NIH, and they're now all of them leaders in the field of toxicology in the United States, every one of them. And I also trained people from 26 different countries that the countries paid for them to come train. So we had a really international group, and I think really contributed to the literature. So even though I retired from NIH, I'm working way more than full time, still doing lots of research, lots of publishing, lots of teaching all over the world. And I'm really happy to be working here with you all. And you convinced me to do that by all of your goals and ideas. I would like to ask the plenary speaker for today. First, Dr. Kaya, would you come up and say a few words? And then we'll have Dr. Ava Hawk after that say a few words before your opening.
And can we also give their gift to them?
Oh,
They
yes,
as well.
of course.
Thank you. Birazdan çektiği verirsiniz. Kaya hocam olsun. Siz şey yapın hocam.
Dear participants and colleagues, in the first session of the symposium, we will discuss substance use disorders and sexually transmitted infections. What do we know about prevalence and the risk factors? Me, Professor Dr. Süer, and the Professor Dr. Mahmut Çakels Ergören from Medical Genetics and Infectious Disease Specialist, and Professor Dr. Meryem Güvenir from Cyprus Health and the Social Science University. She is a clinical microbiologist. We will present this session. Substance use is a serious problem that affects not only the physical and mental health of individuals, but also the general health of society. Injection drug use is a serious problem that affects not only, injection drug use in particular poses a significant risk in the spread of infectious disease such as HIV, hepatitis B, C, and tuberculosis. The prevalence of sexually transmitted disorders, infections due to risky sexual behaviors due to substance use, along with diagnosis, treatment, and preventive measures will be discussed. The presentation title, Genetic and the Neurobiological Risk Factors in Substance Use, Can early detection prevent addiction? We discuss the importance of genetic factors.
Could you speak up just a little bit so we can all hear you? We were
Okay.
listening hard.
Okay. Preventing the spread of the disease is possible not only through treatment but also through a preventive, protective, and inclusive approach. Our responsibility as a society is not to exclude individuals, but rather to provide them with a safe environment where they can access healthcare. Pre-insulin programs, regular screening tests, vaccinations, and addiction treatments are the most fundamental steps in the process. At the same time, promoting safe sexual behaviors and reducing stigma are also critical to preventing transmission. We must not forget that the most effective method is combating infectious disease is prevention. The health of the individual means the health of all of us. Therefore, each of us bears a responsibility both as a healthcare professionals and as members of society. I believe that today's meeting will be a powerful step towards facilitating access to healthcare for individuals who use drugs, preventing the spread of infectious disease, and raising public awareness. Thank you all for your participation and sensitivity, and I hope you have a productive meeting. Thank you.
Thank you.
Yeah.
Okay. So my name is Prof. I'm from Munich in Germany, and I want to thank the conference organizers for this kind invitation and this really beautiful conference venue. And I want to extend a warm welcome also to all people who are following us online. Yeah, I'm trained as a psychologist, and I'm the director of the Institute for Therapy Research. It's a center for mental health and addiction research in Munich, and I'm also a chair of clinical psychology and psychotherapy. So I have now 25 years of experience in research, substance use research, and also substance use treatment. And above all, I'm also the sister of a brother who died in drug-related death. So I know it personally, what it means if someone passes away and what it means to the families. And that has always been something that was driving me to continue to do this work, even when it's sometimes truly difficult. So now I'm also the president of the German Society of Addiction Research and Treatment, and the second vice president of the European Federation of Addiction Societies, EUFAS. And this may be an option to work together and to network. This is why these meetings and conferences are so important, because we're seeing each other, we are sharing knowledge, and we can build links and cooperations. And I would love to do this also with Northern Cyprus, Turkey, the United States, and who else wants to join? So yeah, I have been working in a psychiatric hospital for about 10 years, and I was the lab psychologist, and I was responsible for detoxification and daycare units. And we saw many people with severe dependence, and of course also many with comorbid mental disorder. And this is the topic of my plenary talk tomorrow. And we'll have a focus on, the most important comorbidities, why it's so difficult to treat these people. We have a look at the treatment barriers, and most importantly, on possibilities how to overcome these barriers. And I think it's truly important for clinical practice to know the most effective strategies to manage these co-occurring conditions. And then we'll have a look at treatment guidelines, clinical trials, meta-analysis to get to know what's the best evidence and how to implement this in clinical practice. So I'm looking forward to seeing you tomorrow, and yes, let's have together an exciting conference. Thank you.
Thank you. Thank you.
Yes.
Hi. Thank you.
Thank you.
Hi, good afternoon, good morning, good evening. I'm Dr. Castanetto. My other half is Colonel Castanetto. I am a toxicologist for the military, but for the most part, I've been a researcher on and off. I have a background in biochemistry. I also have toxicology, as Dr. Eustace mentioned a while ago. I manage the Army program. We have labs that we do manage. So part of my responsibility is actually not only ensuring that our drug testing program, it is by regulation, as most, whether you're federal or state, you do have laws to help to follow. So my job is to make sure that we are actually following the program, and also ensure that the program that we do is appropriate for the people we serve, right? So whether you're civilian, whether you're military, we want to make sure that the program is appropriate for that. In the military as a whole, we have different rules. In the civilian, we also have different rules as well. If you test positive for drugs that are controlled, you're not supposed to have it in your system, or if you actually are taking medication that you're not supposed to have in your system. So the talk that I'm going to be covering would be potentially, one, how do you create a program from scratch? Like, how do you actually build it? And two, what do you need to make sure that it is successful? And three, how do you sustain it? So I'm the program manager today, could be somebody else tomorrow. In my nature of job, we always change people. So what I'm going to be pretty much discussing is how do you keep going, and also how do you plan to or plan for the future, whether you're innovating today or changing your method tomorrow. So my peers will actually go more in depth on the details of the methods. For me, it's more of a program. So I am looking forward to the presentation, and thank you for the invitation, and I love this place.
Professor Dr. Mehmet.
Oh, tell us something about
I'm going to talk
you.
to
Can't take your gift and run.
I'm Mahmoud. You can call me Mamo for short. And I'm a geneticist, medical geneticist, and I've been working in the field for more than 20 years. And I'm going to give a talk later on, different, that's different than what is a psychological view. I'm going to give a talk about the geneticist view of tobacco and alcohol use. I'm going to present the studies that we have done in North Cyprus and how we contributed to the world population data. I will try to be not boring while talking about the genetics.
You won't be. I'm sure.
Thank you. Thank you.
Ayva?
Hi, I'm Dr. Kayla Ellison. I did my PhD under Marilyn Eustace. I have been the Deputy Chief Toxicologist for a medical examiner's office in Texas for the last 9 years. My research background was part of an IV cocaine administration study where they were looking at potential markers to put into treatment medication. And subsequently, along with that, we got to test a variety of different alternative matrices and develop detection methods for cocaine and its metabolites. And then the other part of my research background is on the novel psychoactive substances, or back then they were called designer drugs. So we were part of the NIDA Designer Drug Initiative. So we studied a bunch of these new novel psychoactive substances, characterized their pharmacokinetics, pharmacodynamics, and got to learn a little bit more about them. And so part of my fascination with NPS has led me to be the chair of the Society of Forensic Toxicologists NPS committee. I've been a part of that committee for 8 years now, and I love NPS. So tomorrow you will get a talk on some of the challenges of NPS and kind of how we can navigate them, those overarching challenges, but some of the more analytical, technical challenges. And then we'll touch on some of the trends that we're seeing in the United States. And I'll provide some case examples to kind of go over the dangers of these substances, especially in postmortem cases. So I'm very happy to be here. Thank you so much for the invitation, and welcome to everyone online.
You like your present?
Huh?
Oh, you're Erin Spargo.
Hello, I'm Dr. Erin Spargo. I also was a former graduate student of Dr. Eustace. I graduated with my PhD in 2007. During my time with Dr. Eustace, we did a controlled MDMA administration study, which was fascinating. Had a number of research articles that came out from it, and now almost 20 years later, we had another one that came as they're doing research into the use of MDMA for post-traumatic stress disorder. Upon graduation, I worked at a few different public laboratories in the United States, out in the state of Washington, and then I was down in Texas for over a decade, where I was the chief of forensic chemistry. So I was involved with both forensic toxicology and controlled drugs. Since 2020, I've been employed with NMS Labs outside of Philadelphia, Pennsylvania. We're a large clinical and forensic toxicology laboratory. We do more than 60% of the postmortem testing in the United States. So my talk tomorrow will focus on postmortem testing, our approaches, the different things you see in the laboratory. So I appreciate the invitation to speak and look forward to giving my talk tomorrow. Thank you.
Professor Dr. Megan.
Okay, hello. My name is Megan. I am the medical microbiologist. I come from Cyprus. First of all, I want to thank you for the committee and my mentor, Suer, to invite me to be here and meet you. I'm a little bit the same with Mahmoud Hoca. Today, I will talk with you the microorganisms. I like it so much. But there's an important different part that we are going to try to make the diagnosis for especially these groups of the patients. How can you make the diagnosis? What's the prevalence of the world and in some countries? What we are going to change to prevent these infections? I hope that you're going to be like it. Thank you.
Melis.
I wasn't expecting.
Should I talk as well? Or?
Yes.
Oh,
Yeah.
I'm Kiki. I'm a PhD from Leiden, the Netherlands, and I will be giving a talk tomorrow about a new way of detecting drug use with just a smartphone. So yeah, tomorrow.
Have you?
Ah.
Marianne is part of the Anti-Drug Commission in Cyprus. She is responsible with public relations.
Oh, fantastic.
By the way, they are sisters.
Thank you very much.
Okay, beautiful.
So we have a break. We have break. We don't have break. Okay. So.
Can you see? Yeah. And on that side.
Hello, everyone. Forget to introduce myself. I'm Professor Dr. Infectious Disease and Clinical Microbiologist. I became a specialist in 1998, and until today, I'm working as an infectious disease and clinical microbiologist. My article is less than about 180. Maybe one day I will reach to more than 500 articles. I will talk about the integrative infectious disease prevention into substance use and intervention strategies. Preventing and controlling infectious disease in people with addiction is important to reduce the incidence of the emerging disease because a lot of infectious disease will be together with them. The group has several goals for infectious disease by 2030. These goals include controlling hepatitis B, C, HIV, and tuberculosis and sexually transmitted disease, and also some neglected disorders like malaria, neglected tropical disease, waterborne disease, and complex. As you know, in the hepatitis C, treatment which is used 2011 direct-acting antiviral drugs. The population started very quickly decreased who has the transmitted infection to other person. This is the a little bit affected, depends on the COVID-19 outbreaks, but the World Health Organization planned 2030, maybe one decade more, they will eradicate hepatitis C from the worldwide. And also B vaccination is used in most of the countries. I will talk in the later about all these things. The WHO takes every member of society into consideration when setting these goals. It is known that there are diseases that are more common in the people who use drugs. Approximately 60% of hepatitis C transmission is seen in people who use intravenous drugs. It's clear that intravenous drug use is significant contributor to global burden of disease, as which hepatitis C, undiagnosed and untreated HIV and hepatitis B infections are also important source of risk for transmission to individuals who inject drugs and those who do not. Diseases in individuals who inject drugs include hepatitis A, B, C, D, all of them, and HIV, secondary bacterial infection, sexually transmitted, especially syphilis, human papillomaviruses, and chlamydia and gonorrhea is more common, and some respiratory disease, COVID-19 influenza, and tuberculosis. Drug addiction still remains a serious problem in many countries around the world. The drug addiction was 20% increase in the number of drug users worldwide between 2012 and 2022. People who use drugs in 2022, about 292 million people. Most of them use the cannabis, about 228 million, and the other groups is less when you compare the cannabis usage. In the last 10 years, increased at least 20% new addicted people. Despite the fact that approximately 64 million people worldwide suffer from the drug use disorders, and one of the 11 drug users can reach the treatment, and the woman is treatment rate is very low when you compare the male. And the 80 women, only one of them has reached the treatment, and the man 7 to 1. These deaths attributable to the use of drugs between 1991 to 2021. Indirect self-harm maybe is less, but indirect hepatitis C, hepatitis B, HIV, and the other drug use disorders, all of them has killed too much people, which are using this kind of drugs. By determining the intersection points of the infectious disease expected to be seen in individuals with substance addiction, the incidence of infectious disease can be reduced through preparation. These measures could include collaboration and the government support among addiction treatment, psychiatrists, public health experts, infectious disease specialists must work together for this one. Prisoners are considered to be at high risk of exposure to hepatitis, HIV, and tuberculosis. There is also evidence of drug use in the prisons. Infected individuals in prison pose as a risk to both other inmates of the and prison staff. Hepatitis B is less prevalent in drug users United Nations resolution requires countries to ensure that the healthcare provided to prisoners is equivalent to that provided to other individuals in society. The International Drug User Health and the Hepatitis Network, Prison Network, was established in 2019. Its primary purpose is to connect the global community working to improve access to hepatitis care in prisons. Hepatitis B and C are commonly detected positive in individuals who have previously used or are currently using drugs. Due to the high prevalence of hepatitis C in drug users, the European Association Study of Labor stated that all barriers to accessing treatment for people who inject drugs should be removed by 2020. This will increase the chance of achieving the goals of the WHO 2030 viral hepatitis eradication. In the nationwide, the people can reach the treatment about 90%, but in the prisoners, only one, five of them has reached the treatment, only 20%, taking the anti-preventative treatment. One of the study from the Wales in the hepatitis C virus treatment in a short stay prison. In this study, they proposed to check the old prisoners when they come to prison, first jail, first day, and they will increase the catch the hepatitis C virus patients and start to early start to treatment. What's the model? Point of care testing. Everyone arriving to prison is included in hepatitis C antibody screening. On the first full day in the custody, samples are taken via months swab. And if the hepatitis C positive, as a reflex, then hepatitis C virus RNA testing is used, and then the result evaluating the hepatological needs, and also the person had the physical examination, and then treatment begins, and then the treatment monitoring. Because in the need hepatitis C virus drugs, only 3 months is enough to reach 95 or 99% of the treatment to clear hepatitis C virus. In this study, in this trial, what were the outcomes? People screened before the trial, only 110 people screened. During the trial, it increased about 8 folds, 835. Referred for RNA testing, it was only 18, but now it's 93. And also started treatment, it was in the only 4 people, but now it's 32% started treatment. And also in the past, to diagnose and evaluate the patient and start the treatment, it takes about 15 weeks. But now with this trial, with the micro elimination program study in the Wales Hospital, it's less than 1 week, they start the treatment. The lifespan of hepatitis D virus is associated with the hepatitis B. With the introduction of hepatitis B vaccination, the prevalence of the hepatitis D tends to decrease, because as you know, the hepatitis D virus cannot live without hepatitis B capsids. The prevalence of hepatitis D in hepatitis B virus carrying individuals worldwide is estimated about 5%. Now in the worldwide, about 350 million people have been infected with the hepatitis B. Hepatitis B and D positivity are reported to be more prevalent in the countries with the inadequate vaccination coverage, among hemodialysis patients, and among drug users. As you know, hepatitis B diagnosed in 1963 and the vaccination started in 1980s. In Turkey, the hepatitis B vaccination by the government started support in 1996. In northern Cyprus, by the government started support for the hepatitis B vaccination in 1999. In the last 2 decades, the incidence of the hepatitis HIV infection, particularly in some high-income countries, has tended to be declined due to both increased access to diagnosis and treatment and harm reduction practices. Changes in people's behavior after drug use and unprotected sex also have a positive effect on the spread of the HIV, who shown that World Health Organization showed that 5.7% of the reported HIV positive cases are related to intravenous drug use. Injection drug users are at increased risk of developing soft tissue infections also due to the repeated infections. Without appropriate treatment, systemic infection can occur, such as infective endocarditis, septicemia, and osteomyelitis. Staphylococci and streptococci are frequently identified as the etiological agent of soft tissue infections resulting from IV drug use. The spectrum of skin infections seen in the intravenous drug abusers can be quite wide. They can progress from the uncomplicated cellular sepsis, deep tissue necrosis, and necrotizing fasciitis. The risk of developing tuberculosis increases in people who use drugs due to the interaction of multiple factors, including infections, malnutrition, poor living conditions, tobacco, and the alcohol use. The concept of health promotion is defined as the process by which individuals control the factors that have a positive or negative impact on their health and improve them when necessary. The concept of health promotion for people who inject drugs aims to reduce the risk of individuals contracting and transmitting the infectious disease through drug injection and other routes by practicing the safe behaviors. Structural and the individual factors should be addressed and evaluated by the relevant units to improve health. The synergistic effect is evident when structural and individual factors are implemented together. Structural factors may vary from country to country. Therefore, it means removing barriers to assessing the health care for every individual in society. At the structural level, two recommendations for people who use the drug includes optimizing access to health care, decriminalizing the possession of the injection materials, and addressing violence against people who use drugs, and reducing stigma. Individual factors, health promotion activities should focus on safer injection practices, reducing injection frequency, switch to non-injection drug use, and cessation of drug use if possible, safer sexual behaviors, vaccination for vaccine preventable diseases, and routine testing, ensuring the administered treatment. Such infections generate serious consequences not only at the individual level, but also at the social level, giving rise to both direct and indirect costs, These include the loss of productivity, high treatment and care expenditures, and potential transmission to individuals who do not use the drug via injection. Injection drug use remains a significant risk factor for the acquisition of bloodborne and other infectious disease. The prevention and control of infectious disease among individuals who inject drugs is of particular importance, as these conditions have a marked impact on both quality of life and the life expectancy. The actions to be taken at the intersection points to reduce the risk in drug users, provision of sterile syringes and the equipment, and the treatment of drug addiction, vaccination practice for the drug-addicted individuals, screening tests for infectious disease, treatment of the infectious disease, and drug consumption groups providing supervised injection facilities. Provision of the sterile syringes and equipment. The first area of intervention is the provision of the sterile injection equipment, which lies at the heart of the harm reduction approach. Materials such as syringes, needles, and some equipment for the use of intravenous drug can be supplied through fixed sites, pharmacies, prisons, and the peer-based programs. Preparation equipment help reduce the risk of infection. In addition, needle and syringe programs serve a functional role in providing counseling and referrals to health services. NPS have been found effective in reducing the HIV transmission and risky injection behaviors, although evidence regarding the hepatitis C virus remains limited. Although data on NCBs implemented in prison settings are insufficient, the principle of equivalence of care is essential for providing this service. While the effect of services delivered through pharmacies on HIV hepatitis C virus outcomes are uncertain, they demonstrate a moderate and similar success in reducing the high-risk behaviors compared to other NCBs. The success of the adoption services depends on the accessibility and population adapted distribution models. In practice, the required equipment should be provided free of charge. Some chemical agents and secure disposal containers must be also be supplied. Training personnel to prevent stigmatization, especially in the non-specialized settings, is particularly important. And the treatment of the drug dependence, treatment for substance abuse, aim to prevent health harms related to substance use. This approach encompasses the pharmacological, psychological, and behavioral strategies that can be implemented in the outpatient or inpatient settings. Opioid antagonist therapy is the most commonly used pharmacological modality. It alleviates withdrawal symptoms, reduces drug cravings, and reduces illicit drug use and injection behaviors. There is a strong evidence indicating that opioid antagonist therapy reduces risky injection behaviors and injection frequency. Studies have reported that OIT can reduce the risk of acquiring HIV hepatitis C virus among people who inject drugs by approximately 50%. Moreover, when OIT is combined with the NCBs, the risk of acquiring hepatitis C virus has been shown to decrease by up to 70%, 74%. And vaccination is the most effective intervention method for preventing infectious disease among people who inject drugs. Vaccination programs should be implemented for the drug abusers population in accordance with guidelines. These individuals are at risk of contracting co-infectious infections such as hepatitis A and B, and require appropriate vaccination protocols. As you know, if we vaccinated any person against the hepatitis B virus, automatically we have the prevention against the hepatitis B. But hepatitis C, we don't have any vaccination yet, and also HIV. A study of people who inject drugs found that more than half of the participants lacked protective antibody levels against the hepatitis A and B, and approximately 1/4 tested positive for hepatitis C virus infection. This situation highlights the risk arising from hepatitis C virus co-infection alongside A and B infections, thus highlighting the needs for direct vaccination against these pathogens. Vaccine recommended for people who inject drugs, COVID-19, influenza, tetanus, human papillomavirus, and pneumococcal vaccine. To increase vaccine accessibility, vaccination are recommended to be administered in fixed clinics, public services, and correctional facilities. Integrated vaccination programs within the National Health Service providers can both facilitate access and offer cost-effective advantages. And the last one, infectious disease testing for the people who inject drugs. The fourth area of intervention involves implementing voluntary and the confident infectious disease testing for individuals who use drugs with informed consent. Universal testing for HIV, B, hepatitis B, C, and sexually transmitted infections should be provided. Sex partners of individuals diagnosed with the B, C hepatitis and the HIV should be screened in accordance with legal guidelines. The prevalence of the STD is high among people who inject drugs. Significant association have been identified between the intermittent drug abusers and the STDs diagnosis due to risky sexual practices. Commonly detected STDs are chlamydia, gonorrhea, syphilis, and herpes. These findings highlight the need for targeted voluntary and public testing strategies for against this infection must be used. Infectious disease testing for people who inject drugs are at high risk of both latent and active tuberculosis also. And disease prevalence is particularly high among HIV positive individuals as a co-infection. Preventive interventions are being integrated into TB clinics and needle shrink programs. Concurrent administration of NC-ADC and opiate antivirus therapy has increased the TB screening rates and improved the adherence to integrated TB tuberculosis treatment regimen. Effective models are characterized by the integrated collaboration, person-centered care, and the integration of social support services. Surveillance system for TB and co-infections among the people with disabilities need to be strengthened, and the access to OIT needs to be improved. Surveillance systems for TB and the co-infections. Effective antiviral therapies for hepatitis B, hepatitis C, and HIV play a critical role in preventing transmission by reducing viral load. Direct-acting antiviral used in the treatment of chronic hepatitis C negatively impacts hepatitis C virus RNA and provides a sustained virological response. Only 3 months treatment is enough in this period. These treatments are well tolerated and effective even among individuals receiving opioid agonist therapy who continue substance use during treatment. Antiviral therapy for hepatitis B virus can suppress viral replication, reducing progression of the cirrhosis, the development of hepatocellular carcinoma, and liver-related deaths. In context of HIV, antiretroviral therapies suppress the viral activity and halt disease progression, regardless of CD4 count or clinical status. Antiretroviral treatment is initiated in individuals living with the hepatitis HIV upon diagnosis and continued for life. Identifying high-risk individuals, such as persons who use intravenous drugs, and providing the appropriate preventive treatment is crucial. Effective TB treatment options are available to prevent morbidity and mortality and transmission. An individual's immune status is the most critical determinant of the progression from latent TB infection to active disease. Effective antibiotic protocols are available for common sexually transmitted infections such as chlamydia, gonorrhea, and syphilis. And PWID are susceptible to skin and soft tissue infections. Early diagnosis and treatments of the soft skin tissue infections are crucial. Causative organism, as said before, Staphylococcus and Streptococci. Treatment generally include drainage and antimicrobial therapy together. And the drug consumption provides and supervised injection facilities. This includes providing supervised injection facilities where people who inject drugs can use the substance obtained from the other source under the supervision of the trained personnel and under hygienic conditions. In these facilities, staff can provide sterile injection equipment, provide information aimed to reducing the risk of the transmission of bloodborne infections, such as hepatitis C, HIV, conduct necessary screening tests, and facilities access to treatment support. These measures are thought to be contribute to reducing the risky behaviors and infection rates among the PWID individuals. In the conclusion, the ensure sustainable impact, these interventions must be complemented by the robust educational infrastructure. Harm reduction principles should be integrated into medical, nursing, and public health curriculum, and continuing professional development programs should train healthcare professionals on NSP, OIT, and vaccination protocols. Interdisciplinary workshops should support team-based clinical decision-making, and the digital health training should address psychosocial support provision and equity of access, and correctional facility training should support care equivalence and be competent. Thank you very much.
Do we have time for questions?
Yes, sir.
Thank you so much for your interesting lecture. I have a couple of questions. So at the National Institute on Drug Abuse, in our participants in Baltimore, Maryland, we had 95% incidence of hepatitis C. 95% had hepatitis C. One of the big interventions was treatment for HIV, and the others, injections, whatever. I spent 4 hours at the injection site in Switzerland, in Zurich. And I was really impressed by the reduction in the number of overdoses and deaths of the population. But I was really appalled at the amount of blood that was everywhere when people came in to inject. Blood everywhere for infectious disease purposes. And immediately I asked, the individuals came in, they chose their own dose of heroin. They injected not in a manner that I thought was appropriate, but immediately they were escorted out the door. No place to lie down and nod out or whatever, immediately right out the door, which I thought was dangerous for themselves and for others. And the other factor is when they tested the urine, even though they're allowed, my first question was, how many hours a day are you open? And they're only open 8 hours a day when people need approximately three injections a day if you are a heroin or opioid addict. And so they gave take-home doses to people, which then they sold to other people. And when they tested the urine, they found acetylcholine and other markers of non-sterile heroin. So I think it's very difficult to have these, it's very difficult politically to get support for the injection facilities, but I think we are not providing what's needed for the individuals as well as maybe society, because they found needles all in the parks and things like that. So what would you think, and what can we do to get a better injection site that better serves people?
It's a very difficult question. It's not easy to explain how we can make the injection facilities area. I think the governments must support too much for this situation. As an infectious disease specialist, I know I can say the hepatitis C virus, you said everywhere as well. Hepatitis C virus can live about maximum 3-4 hours outside of the human body. That's why can transmit the infection with this way also. I think these injection facilities areas are, don't know how can I say, it's not easy to take under the control, because the people who comes there, they need the drug. That's why the behavior is different when you compare to normal people.
Thank you very much for your very comprehensive overview and also the evidence that these programs are effective. So what I'm interested in, coming from Germany, it's a rich country, but we see a lot of cuts in budgets, especially when it comes to substance use disorders. What is your experience internationally, Turkey, Northern Cyprus, other countries? Are these evidence-based harm reduction approaches, are they implemented? Is there given money because there is evidence, or is it getting less? So where we are now?
Now I'm living in Cyprus. That's where I know something about the Cyprus country. And maybe the steps that they will have us against this question, because I don't know which kind of precautions taken in the northern Cyprus. I work at the hospital. In the outside, I don't know the real situation actually.
instead of translating, I was talking to her in English, and I was just wondering how it comes that she didn't get it. Okay. Şimdi bana.
Tabii çok daha iyi bir geçmişe beraber destek, iyilik,
If you compare it with the past, it's getting better if if we are talking about the northern side of Cyprus. Maybe in the past it was not that good, but now that later they're getting better support, including the individual parliamenters and etc.
I will say one thing that I was very impressed with in Switzerland was the barrier to treatment is very large to go to hospitals and the stigma against people who use drugs. But they put the physician in the safe injection facility, making it much easier for them to get health care. And that was a huge aspect of it. I don't know much about hepatitis D. What can you tell me? What's different about D than B or C or A? And you say we don't yet have an injection, a treatment for it, correct?
Hepatitis D.
D.
Hepatitis D virus, also called as a Delta virus, cannot live alone in the human body. This hepatitis D virus needs the hepatitis D virus capsid amount. If the patient, if the person has the hepatitis B, and then added the hepatitis D, we call Süer infection. And if any person infected with the hepatitis B and D in the same time, we call it as a co-infection. And hepatitis D also can make the chronic liver disease, like the hepatitis B. That's why the intravenous drug users, if they have the hepatitis B, also can transmit the hepatitis D. All the infectious disease, hepatitis D guides and hepatitis B guides says that when we diagnose hepatitis B, we have to check Delta virus, hepatitis B also. But in the worldwide, there are a lot of study about this one. Most of the people, doctor, forget to check the hepatitis D virus. In the intravenous drug users, about 5% people infected with the hepatitis D. Totally in the worldwide, some article says 50 million, but in reality, at least 75, 100 million people infected with the hepatitis D.
You said that relatively a lot of men that are substance use that have a substance use disorder get treated, but relatively little women. Why is that so different?
When I read this part also, I ask this question to me, and the men take the treatment more easily when they compare the women. I don't know why the woman didn't take this treatment. There's some article explain this one is the women's, especially in the undeveloped countries, they evaluate as a second class person. That's why they cannot reach the treatment.
Is it more stigma?
More stigma,
Yeah.
of course.
I know in the US it's very difficult to find programs for women, especially if they are pregnant or have children, need childcare and that kind of thing. It's very difficult to find a program that helps support them.